All right, well, in keeping with AUR punctuality guidelines, I think we'll get started. I want to thank everybody for coming to this 4 o'clock session, Survey Research for Residents at Primer. My name is Adam Tallenfeld. I'm a faculty member in the Interventional Radiology Division at Cornell. And I'm not certain, but I have a suspicion that the reason I was asked to moderate this session is that somebody at AUR heard I was planning on using survey methodology to assess an ultrasound hands-on course I'm going to be doing next month at the college, and I could probably use a little bit of help. And they were right. And so for that reason, as well as my own genuine interest, I'm very much looking forward to our expert panel of presenters. So with no further ado, it's my pleasure to introduce Mark Hammer. He's the chief resident at the Mallinckrodt Institute in the Washington University in St. Louis, and the A3CR2 Survey Committee Chair, as well as Jiga Sisman, who's chief resident at UNC Chapel Hill and president of the A3CR2, and their talk is the A3CR2 Annual Survey, Goals and Intent.
Hey, how's it going? So I'm Jiga, I'm from UNC, and I'll be doing sort of the first part of the survey. So the purpose of the annual A-Cube CR² survey is, well, I guess let me actually look at what my slides say. So the first thing is these are our learning objectives, is to understand the purpose of the survey, describe the design of the survey, and list some of the challenges that are presented when we design and implement and analyze the survey. So the background, this survey initially got started in 1971, and the results are presented at the beginning of the conference in an effort to inspire discussion and ideas during the conference, as well as to see how different programs take care of benefits and call and things like that. And they help to form questions and things in the idea forms. So that's sort of the background on it. The goals is to understand the experience of the radiology resident, including benefits, call, board preparation, and also understand the trends in residency programs regarding facilities and coverage. Specific things that we look at are case volumes, overnight attending coverage, and the other things that we like to take into account are the current job market, fellowship interests and fellowship markets, how the trends in that are changing. And we try to put together data so that residents at institutions can sort of see how other places are solving problems, as well as understand the duties of the chief of residence and some of the benefits that are had around in case they want to go changing their institutional benefits. So this is sort of the application process, and we try to look at trends in the data, both in terms of how residency programs solve problems, as well as perception of the job market, the number of women entering radiology, and then we try to use those results, like I said earlier, to influence those outside the A-cubed, as well as higher level decision makers like the ABR. And so we can use this as an opportunity to show sort of the national trends of how the residents feel about issues, and it's in an anonymous form, so that usually brings out more truth than speaking face to face. And so participants, there's approximately 187 ACGME accredited radiology residency programs. There's also additional osteopathic and Canadian programs that belong to the AUR, and so what we do is we send these the survey out via the AUR mailing list, and if once we get those desired responses, we also email Lori May from the RSNA to try to distribute the survey to institutions that have not responded yet. And so we collect the individual responses and organize them by program. So if we have two sort of data points, we have unique entries, and then we also have entries by program. And so, like I said, it's an online survey that we distribute via SurveyMonkey, and the responses are anonymized, and then it's open for about 2 months, and we send reminder emails to the chief residents to fill them out.
Thanks, Gia. I'll just kind of go through a little bit more kind of the nitty-gritty here. So we have a variable response rate. As I said, there are about 180 to 190 programs total in our organization, and we've gotten response rates ranging between, as you can see here, about 50 to 80%. This year's response rate was 64% of programs sent at least one response, and you can see there are 193 individual responses. Many of those were multiple chief residents per program. As Jiga noted, and you'll see in a little bit, some questions kind of are program questions, like how many residents do you have? So obviously they're all going to be the same answer for the individual program, but there are other things about attitudes and that sort of thing that the individual responses are, important and maybe different. And I was mentioning the survey is long. We keep it as short as we can, but it's still somewhat long, and so they're not all of the responses are complete. And some of the questions are chief residents don't always know, depending on the institution, the answers to all of the questions, and you'll see some of that in a little bit. So just showing the actual responses this year. As I said, there were 193 responses from 120 programs. You can see it's pretty geographically distributed, probably, just reflecting, again, the underlying sort of distribution of the programs. And then, as far as university hospital versus community hospital and urban versus rural, again, obviously there's a disparity here which reflects the underlying distribution of the programs. But, we do get responses from all types of programs. And so just to outline the kinds of specific things that we ask on the program, in the survey, program details, like, as I mentioned, sort of number of residents and that sort of thing. We ask a lot about resident benefits, what perks do you get? Do you get to, go to conferences? You get meal allowance or parking, rad primer subscriptions, that sort of thing. We also ask about chief resident benefits and chief resident responsibilities, which differ among programs. Some chief residents do call schedules, some don't, some do vacations, et cetera. We then kind of more broadly ask about how call is handled in individual programs, and what kind of attending coverage they have on call. Questions about board preparation resources, dedicated study time that's provided at each program, how programs sort of implement their mini fellowships or selectives in the fourth year. And then also, as Jiga alluded to, we ask about people's fellowship choices, which we trend over time. And then also, feelings about healthcare economics and job market, people's perceptions about the job market, which we know have been sort of fluctuating quite recently, quite a bit. And then some miscellaneous questions on things like PQI projects and the milestones. So since this is kind of about survey research, I thought I would sort of describe exactly what kinds of questions we do ask. A lot of the questions are, and as many of you have filled out the survey, you'll know, a lot of them are these sort of multi-option selection questions. So for example, what kind of call shifts do you have at your program? Do you have night float? Do you have weekend shifts? Do you have like individual evening shifts? And many programs have multiple different ones of these, so you kind of mix and match and choose whichever ones fit your program. We do have a few of these like kind of Likert scale type questions where what is your feeling about the job market? I feel great about it. I feel okay about it. I'm very worried about it. So there's a scale from 1 to 5 on some of those questions. And then we also like to include free response boxes for each of our sections, each of these sections that I mentioned here, so that people can provide sort of write-in answers. And some of those have inspired, future questions like next year's survey. Oh, that's very interesting. Some people mentioned that they have this program. We can, systematically ask it next year, for example. So as I mentioned, most of the questions are kind of reused and adapted from last year's survey. But each year we, add questions based on, as I said, past year responses. also the A-Cube Executive Committee, we all discuss and kind of have input. And then also, kind of looking at the current events and broader trends. So we had some more stuff, for example, this year on IR, given the anticipated changes in the creation of this new IR residency. And we try to trim the length of the survey as best we can. It is very long, but there are a lot of things we want to ask about, and there are a lot of things we want to trend for the future. They may not seem that interesting now, but it'll be interesting to see how they change over 10, 20, years. In particular, this year, changes that I made, we asked kind of about, so it's, new things. So for example, the core exam, some programs are providing stipends for people to travel to the core exam. So that was something that we asked, and obviously would not have been relevant a couple of years ago when the core exam did not even exist. And some, other things about core study resources and moonlighting and the IR that I mentioned. We asked some more about IR fellowship numbers to see what, again, anticipating trends that we can follow over time. I personally removed some of these attitude questions about the core exam and milestones that were present on last year's survey because I wanted to focus a little bit more on concrete things, what exactly is changing and what can we measure, and then we can use that, sort of make conclusions based on that. The fact that all residents don't want to take a test is, I don't know, we need to have a survey to find that out. So challenges with the analysis, and I hope that our future, the rest of the speakers in this program will maybe help us solve a lot of these challenges. But so incomplete surveys I mentioned earlier, it's a long survey. People may have kind of stopped in the middle middle of the survey. Some questions people don't know the answers to. Maybe they weren't worded correct, very well. That's another possibility. There were some inconsistent answers among different respondents from the same program, or even within certain of the multi-selection questions, that maybe they clearly weren't worded very clearly, and so there were some sort of inconsistent answers to those questions. As I mentioned, residents may not know the accurate answers to all of these questions about volumes and the number of paid number of residency slots per their institution, that sort of thing. There are things that are at high levels, and some programs, chief residents are kind of in the know, but that's not the case at all programs. One question that I have that, sort of to ponder is, is a sample of respondents biased? It's always an important question in surveys. We do have responses from a large fraction of the programs, but certainly not 100% by any means. And so, you might wonder, is there a bias in the people who respond and the types of programs they may be from? It's a little bit hard to know, although, as I said, we do have a large fraction of programs, and we seem to get a good mix of different types of programs. Another challenge for the analysis for historical trends, we don't always have complete data from prior surveys, or sometimes questions weren't asked on certain years, so it's something we have to kind of work around. I thought I'd just kind of leave us with a couple of interesting historical trends that I look back on some rather old surveys to see. So women in radiology, it's just been a perennial problem. So from the survey in 1996, 1/4 of the radiology residents were women, and in 2015 we've made great progress in that 1/4 of our residents are women. There has been progress, in fact, though, in medical schools. So we've been able to increase the fraction of women in all residencies from 36% in 1999 to 46% in 2015. So that's been actually a success, but unfortunately not in radiology. Night float, so that's another interesting trend to look at. In 1996, 42% of programs had a night float system, and in 2015, that's 81%. And that's probably related to the ACG, the changes in duty hours that people, changed their call system to, so there weren't any duty hour conflicts. And then the last little thing to look at over a long period of time is salaries. So the dark red line here, this one is the Consumer Price Index, which represents a measure of inflation over time. And so you can look, and that's graphed on this right axis here. And the two lighter colors are the actual salaries for PGY 2 and PGY 5. And you can see the salaries have actually increased greater than inflation. So that's some good news for us. So I'm going to end here. Does anyone have any questions about the survey? So we have the raw data at Mallinckrodt for all of the years. So the survey presentations for at least the last, I'm not sure how many years, the last quite some number of years, 4 or 5 years, the presentations are available on the A-Cubed website as well. But you know, if anyone's interested, feel free to contact us. We can provide more data. I mean, the presentation doesn't even include the entire survey because, I mean, it's quite massive, but there's a lot of data in there, and there's a lot of historical data that we have too. And if anyone's interested, we would be absolutely happy to provide actual data.
I think the response rate you're getting, it averages, you know, in the 60s, 70s, up to 80s is a pretty great response rate so far as surveys go. So that's, you know, that's a testament to the organizational, you know, prowess you guys execute. Curious, you mentioned it was long. How many pages long is it? How many items is it? And is there any kind of, you mentioned you sort of have some executive authority to add and remove questions. Is there any kind of vetting process for how to make the decision on when to let a question go in the name of maybe a higher rate of return for surveys?
Sure, that's an interesting question. We are pretty informal about the, you know, adding and removing questions. It's kind of, you know, we take last year's survey, we, you know, change, add things, subtract things, then send it out to everyone and, you know, kind of get a consensus of what people feel. But it's an interesting, you know, point. Maybe some questions could be tried or trialed in some way before putting them in the survey, if that might improve some of the responses. As far as the number of items, you know, that's a good question. I actually don't know off the top of my head. I would estimate it's somewhere around 80 or 90 maybe, something like that. It is quite long. I think, well, here, the number of sort of pages on SurveyMonkey is this. So that's what, 3, 6, 8 pages. But some of the pages are quite long, and you're absolutely right. Some of the things are, I mean, could potentially be cut, but you know, we always, as I said, there's a, you know, conflict between taking out some things that some people may be interested in, you know, or may provide interesting future analysis trends. So it's, you know, just like with anything, we want more data, but you know, there's kind of a tension there.
Is there a microphone? I just wanted to say that one of the reasons why there's so many questions is that thank you. One of the reasons why there's so many questions, it's grown actually since I've been involved for the last 7 years. So it has grown because at the IDEA Forum, which is more of a discussion session, some of the residents would say, how many people and how many programs offer travel for the boards, and how many programs allow this? And it was just surveying informally in the room, and we thought that wasn't a good use of time, and we could just do this. And since there's a high response rate, that response rate I think is high because of the motivation of the chief residents. It's a select group of people who are motivated to respond.
Yeah, absolutely. And I think people are also motivated by the fact that they can use the data. I mean, it's really a practical use for individual chief residents. We personally in our institution have taken some of the data back and said, you know, to our administration, here's how everyone else does it. Maybe you could consider changing it to this, or, you know, it's a kind of actually very powerful data. Any other questions? All right. Thanks.
Thank you very much for that great presentation. Very interesting. And it's with great pleasure that I get to introduce our next speaker. Pari Pandey is an abdominal radiologist, a member of faculty at the Massachusetts General Hospital and at the MGH Institute for Technology Assessment. In addition, she's on the executive committee at the Radiology Alliance for Health Services Research and has published over 40 articles in peer-reviewed journals. So upcoming next, Dr. Pandey Pandey is survey research, key elements, and design.
Thank you so much. Let's get this going. So thanks again. It's terrific to be here today. My talk is entitled Survey Research, Elements of Design. As a disclosure, I received research funding from the Medical Imaging and Technology Alliance. So I'm going to frame this talk around a survey project that I did. And the reason I'm going to do that is because I will share with you some of sort of my failures and successes in that survey project, and hopefully that'll help to illustrate some points of survey design. The survey study that we published is entitled How Radiation Exposure Histories Influence Physician Imaging Decisions, a multi-center radiologist survey study. So I'm going to start with the scenario that we used at the beginning of the survey. A PCP calls you, a radiologist, to discuss imaging options for a patient that he recently saw in clinic. The patient is a 35-year-old man with nonspecific abdominal pain. After discussing the nature of the patient's pain and presentation, and after weighing the risks and benefits of all possible imaging options, you recommend a standard abdominal pelvic CT. You determined that in this patient's case, its net benefit is likely to be superior, albeit only slightly, to all other imaging options. As you're about to hang up, the PCP remembers some additional information. He states that the patient has had 15 prior CT scans totaling 150 millisieverts. These took place after a car accident 10 years ago. Initial scans were performed routinely as part of a trauma protocol, no abdominal injuries were detected, and the patient did not undergo surgery. Subsequent scanning was for follow-up of incidental findings, all benign. You and the PCP agree that the patient's accident and incidental findings are not related to his current abdominal pain. So the PCP asks for your final recommendation in light of the patient's prior radiation exposure history. So the central survey question we were trying to understand here is, do you, as the respondent of this survey, change your mind? And if so, or if not, why? So to provide an overview for today's talk, I'm going to talk about key criteria for study design in 5 domains: population, the pilot phase, the response rate, negative studies, and the importance of considering your effect size before you start your study, and the importance of designing your study with an eye to transparency in your methods and your instrument. In other words, thinking about the fact that you're going to want to put all of that forward for somebody else to be able to look at and use down the line, just as these folks have already told us that they do. So when we think about population, you want to consider carefully your respondent characteristics, and you want to make sure that they're recorded if they could make a difference. The study results can be confounded by respondents' characteristics. So I'll show you an example of this in our study. And in the talk that we just heard, respondent characteristics, for example, pertain to the characteristics of the residents. So here on the y-axis we have the percent respondents, and on the x-axis we have the final imaging recommendation. So after we presented this scenario to the people who were responding to our survey that I just told you about, we asked them what they would recommend next, and they had different options. So they could choose one of what I considered a reduced dose strategy. They could defer the CT, they could recommend an ultrasound, they could recommend a plain film, or they could recommend a reduced dose CT. Or they could stick with that standard abdominal pelvic CT that they originally recommended. Now you'll see that I have these options spread out by what the respondent chose, but I also have them spread out by what the training level of the respondent was. And that ended up being important in our study. So we found that there was a statistically significant difference in the proportions recommending reduced dose strategies across the 3 institutions. So about 66 to 81% of respondents across the institutions recommended a reduced dose strategy. But within that range, they were statistically different. We also found a statistically significant difference in the proportions recommending reduced dose strategies by training status. So on average, the trainees were less likely to recommend a reduced dose strategy than the attendings. Again, a statistically significant difference. So then we did what's called a logistic regression analysis. So we said, when you control for the training status, does institution correlate with whether somebody recommends a reduced dose strategy? And in fact, we found that the differences in recommendation across the institutions disappeared when controlling for the trainee status. What does that mean? That means that the differences that we were observing from institution to institution weren't actually related to the different institutions. They were related to how many respondents within the institutions were trainees or attendings. So it's an example of why it's important to collect that information. So you want to record important population characteristics, and they can be critical for analyzing your results. Other population things you want to think about: is the population generalizable? Would it apply to more than just your institution if you're doing it for just your institution? Is there appropriate oversampling? So what is oversampling? Oversampling is sending out more surveys to one population than another to make sure that they're represented as needed to achieve your study goal. So for example, if you're surveying to elicit perspectives of women or underrepresented minorities in radiology, we've just heard that we don't have as many, and you want more than, on average, 25% of your responses to be from those people, in that case women, but there's even fewer underrepresented minorities, then you'll need to oversample in order to make sure that you have good representation from those groups. So the next thing I'm going to talk about is the pilot phase. So pilot phase is incredibly important in a survey, and formally it's divided into two components. It's divided into the cognitive testing component and the pre-testing component. I'm going to share with you the difference between these two things. And just as an aside, this is not something that's part of certainly anything I learned in radiology training. This is something that I learned by collaborating with a PhD-trained survey research scientist who's dedicated her life to this. And I'll go through a little example of how I could have totally messed up our survey if I hadn't actually gone through this process. So the pilot phase, as I said, really starts with cognitive testing. And this is something that for the chief resident survey, I'd say, if you haven't done, it's one of the things that will help. The whole pilot phase is one of the things that can really help you to refine your survey and answer those things like, are 8 pages of SurveyMonkey questions too long? And which are the ones that people are like, oh my, I just really do not want to answer one more of those types of questions. So cognitive testing gets into that. You give your survey to people who would be eligible. You look at their responses. You ask them what they thought the questions meant. You see if you got it right as the researcher. And I'll tell you that in ours, the first survey attempt that we made, or that I made, really wouldn't have worked. What we did was we presented the respondent with 2 patients with suspected appendicitis. So in our final survey, which was the one that I gave you, that example that I gave you at the beginning of the talk, the patient had nonspecific abdominal pain. But in my pilot, I said, okay, let's present this respondent instead with 2 patients with suspected appendicitis. And I said patient 1 had no exposure history, and patient 2 had 150 millisieverts of exposure. And I said, what we'll ask of the respondent is we'll say, would you give a CT scan to patient 1, and would you give a CT scan to patient 2? I thought this was very smart. I thought, well, I'll uncover the magnitude of people who would be influenced by this 150 sieverts of exposure in patient 2. People would be less likely on average to give that patient a CT scan. And it turns out that I was completely wrong. So when I actually did this cognitive testing, everybody said to get the CT for both patients. And, I said, how could that be? And they said, Pari, if you're really worried about appendicitis, you just get a CT. And in fact, we know that's the case. But when you're developing the survey yourself, you're in a small space. You're thinking about your scientific question. And this is a question that I think about every day clinically. But when I was in my small research space that I was trying to elicit this question, I was I wasn't thinking like the average respondent. And that is the whole point of a cognitive test exercise. And you will be surprised by how often this happens. I would say this is much more the norm than it is the exception, that you will change your survey entirely by the time you actually submit it. So in my original survey design, I would not have been able to distinguish whether or not people used past exposure histories in their decision making. So that's why we switched to that PCP telephone scenario. We needed much more constraint on what we were going to ask the respondent to do in order to uncover the magnitude of the effect we were looking for. What would have happened without cognitive testing? So we would have gotten the results that the cognitive testing subjects gave us, and we would have assumed that most people did not use past exposure histories in their decision making. In our final survey study, we found that 92% of radiologists do. So we would have potentially got a wrong result. So the next part of the pilot phase is pre-testing. It tests the survey architecture. It says, when you send a link, does the survey open? Do the responses record correctly? If you have a mailing survey, do the procedures that you have in place to get the responses back work? If people check off a box, do you know that that box is checked? And again, it sounds mundane. It doesn't sound, I mean, this doesn't sound, it seems to me like prospectively, if you were very, very careful, then you shouldn't have these problems. But again, I think that it's important to recognize you should expect that there will be problems and plan for it and do a very, very thorough pretest. My survey researcher, when we did this study, for example, which was an electronic study in 3 institutions, basically mandated that we tested every single response question electronically before we sent the survey out. And that's what we did. And we did find some problems and we fixed them. And the types of problems that you can find are that they can end up being formatted oddly, or certain items don't end up being properly recorded. So we fixed them before sending them out. What would have happened if we didn't? Well, one of the things, especially about electronic surveys, that's important to keep in mind is if you send out a survey and there's something wrong, you need to resend the survey, you're probably going to lose respondents. And something that we talked about earlier was the response rate. The response rate is probably the single most important thing of your study design. So you don't want to lose responses for something that is preventable. And then there's a potential in a survey like ours, which was essentially a test of the way people thought, you have a potential for introducing bias. If they finish half the survey and then something goes wrong, then you resend out the survey. They could speak to their colleagues. It's a different study. So you don't really, you really want to try to get it right the first time. So now we're going to talk a little bit about response rate. So I'd say that when determining the validity of survey results, a metric that's universally important across all study designs is going to be the response rate. And the reason for that is what's called a non-response bias. And that's the study bias that arises from the failure to capture the input of non-responders. So are your non-responders a different group of people? Are they responding in a way that's different than the people, or if they were to respond, would they respond in a way that's different than the people that actually did? So let's consider this hypothetical study. Let's say you want to know how busy residents are. So you survey them about their time. You say, in the past week, have you been to noon conference? Have you followed up on cases? Have you had lunch? So let's say 25% of the residents respond, but they all respond during their lunch hour. And the other 75% of the residents are extremely overworked during their lunch hour and they don't respond. So they're not, these 25% who responded, they're not busy. They had time to respond to the survey. They all had lunch. They record that they had lunch. So the administration says, well, universally, 100% of the people that responded to our survey seem to have time. So they have more bandwidth to do more work, and the residents become more overworked. This sounds maybe a little ridiculous, but this is actually the way that a lot of survey results get interpreted when you don't consider the possibility of a non-response bias. So the question that's commonly asked is, can high numbers overcome a low response rate? So would that bias go away if you had 10 times the 25 response rate? So let's say you have a residency class of 10 and you have 40 people in your program. What about if 100 out of 400 instead of 10 out of 40 people responded? And that really doesn't do it. It's really about the percentage. The percentage that you folks had in your survey was terrific. So usually, I mean, the gold standard is around 60%. If you can get up to 60%, you're doing really, really well. And I'd say for the top medical journals, that's what you have to essentially hit before you're able to get something in. So that's a great response rate. Will there be some element of non-response bias? Probably, but I would say that, you know, you're never going to be perfect. And I think that that's you know, as others have said, I think that's a terrific response rate. So the next thing I'm going to talk about is negative studies and effect sizes. And in order to understand the importance of this, I'm just going to go over a few basic things in statistics. So a common study goal is that you want to compare a metric between two groups. So let's say a proportion of people who answered anything, X, group 1 versus group 2. There's always two truth possibilities. Either there was a difference or there was no difference. And when there's no difference, we call that the null hypothesis. So the p-value is the probability that a difference as big as that detected would be seen if there was no true difference, or the probability that the null hypothesis was incorrectly rejected. Alpha is the level of significance. P less than 0.05 is called statistically significant. That's something most of us are familiar with. Power is the probability that a true difference would be detected, and we consider 80% reasonable. The effect size is the level of difference between groups that the study could have detected with 80% power at an alpha of 0.05. So the influence on power statistically are threefold. They're the level of significance, or alpha, the effect size, and the sample size. So positive studies are somewhat easy to interpret, as long as you know what groups they're being compared. If the p-value is less than 0.05, there's a statistical difference. Negative studies are harder to interpret. To interpret a negative study well, and therefore to design a study with a potential negative result well, you need to know what the effect size was that the study was powered to detect. And so here, again, don't be fooled by large respondent numbers. This is not going to be a problem that's just going to be solved by numbers. Statistical power has to be a concern in any finding, any study with a non-significant finding. So let's consider another version of the hypothetical resident study that I described earlier. So let's say institution A does this survey and finds that 25% of their residents record that they have time for lunch, and institution B says 60% of their residents do, and the p-value when you compare these institutions is greater than 0.05. So the institution A administrators could say, in this administrative survey, there was no difference in the lunch status of our residents compared to that of other institutions where most residents had time for lunch. A problem with that could be the effect size. So what effect size was that study powered to detect? If it was powered to resolve a 40% difference, then differences that are less than 40%, like that 35% difference, you would not be able to detect. So you couldn't detect what may have been a real difference. So the results aren't really meaningful then for a negative study. So finally, I'm going to talk a little bit about the importance of access to instrument. And I think that that's something that's terrific about what you guys have talked about. You know, when you design a survey study, especially in our field where we don't have that many surveys, you really want to try to make your instruments and your methods as transparent as possible. It's ridiculous for somebody else to have to basically reconstruct the same survey. This should be a process, iterative, as the chief resident survey that gets better and better and better each time. Otherwise, it's inefficient and just makes absolutely no sense. So when you think about designing your surveys, you want to think about them with an eye towards transparency. And again, I guarantee you that when you think about transparency in terms of both putting your items out there and being transparent about how you analyze the items, your actual study will become much, much better. There will be nothing to hide. So when people look at your survey study, they'll say, judge you in part on your transparency. They'll say, do the items address the core study issue? And they'll look at how they're phrased. So I'll give you an example of how we did this in our study. So we had our survey scenario that I presented to you at the beginning of this talk. The patient with nonspecific abdominal pain, which you recommended a standard abdominal pelvic CT for. Then you were made aware of an exposure history. And then you were asked as a respondent the following. This is the first question you were asked. Which of the below options comes closest to your final recommendation? You could defer the CT, you could obtain an ultrasound, you could obtain a plain film, You could obtain an abdominal pelvic CT scan at a reduced dose. All of those we called reduced dose strategies. Alternatively, you could stick with that standard abdominal pelvic CT scan, and there would be no change in recommendation. This is how we analyzed these results, and this is the exact question we asked. If you went with a reduced dose strategy, you were triaged to the following question. The PCP thanks you for your recommendation. He asks you for future reference at what threshold you begin to consider prior radiation exposures in your decision-making process. Which of the below options would best represent your response? So you could pick a threshold of 50 millisieverts, 100 millisieverts, 150 millisieverts. You could say that you did not use a specific threshold, that in your decision-making you weighed the combined risks from the current imaging study under consideration and from prior exposures against the current study's benefit. All of those would be considered using the prior history in decision-making. Or you could say that the basis for your final recommendation did not pertain to the patient's prior exposure history. That would mean that you did not use the patient's prior exposure history in your decision-making. If you stuck with the standard abdominal pelvic CT, you were triaged to this question. The PCP thanks you for your recommendation. He asks why you didn't change your recommendation in light of the patient's exposure history. And you could have said that you thought that in the clinical setting of abdominal pain, the benefits of the standard abdominal pelvic CT would typically outweigh the combined risks of the prior CT scans and the current scan in question. That would be considered, again, using the prior history in decision-making. Or you could say that you didn't think that the risks from past radiation exposure history should factor into prospective imaging decisions, so your recommendation didn't change with knowledge of the patient's exposure history. You did not use the prior exposure history in your decision-making. So in conclusion, I've reviewed some key criteria that I think are important for consideration when you're designing a survey study. I'd say that the most important thing for the validity of a survey study is the response rate. And I'd encourage you to consider the fact that without a good response rate, you could end up putting out a message that's actually incorrect, and you can potentially even do more harm than good. Thank you for your time. I'm happy to answer any questions.
I thought that was fantastic. Thank you so much for that. I really learned a lot. My question for you has to do with validating a survey and whether it's okay, acceptable, I don't really know the word to use, but to use a survey instrument that you create yourself. And how often, and how to validate a survey, because I know a lot of times people use kind of validated survey questions to when they ask their clinical demographic or whatnot. And do you have any thoughts on that, this validation process?
So it's a hard question in the sense that when you, I guess I'll start with your first question. So you certainly should feel free to come up with your own survey items and your own survey questions. The thing that I would say is the advantage of working off of other people's published survey questions, and of course referencing them, is that if the question worked at that time, then you have some internal validation built in. If you develop your own survey items de novo, like we did in this survey, I would strongly, depending on what your background is, I would strongly encourage, if your background's like me, like a radiologist, maybe with outcomes researcher or a radiologist, then I would say I would strongly consider working with somebody who's a dedicated survey researcher, because it seems so much easier than it is. It's hard to emphasize that. It just seems so much easier than it is. And they will provide a level of validation in and of themselves. They'll say this type of phrasing doesn't work. This is known not to work. In fact, everybody in survey research other than you knows probably that this will not work. And so then you say, okay, I won't use that. And so there's some validation that goes in there. And then, you are the validation in the sense that you put the survey out, you get your results, you find what works, you find what doesn't work, you find what responses people don't use, you publish it, and then you work on it yourself. So I think it's certainly fine to do your own survey and your own items, but when I've done that, I definitely have worked with somebody who's far more expert than I am. It depends on how complex your study is. So for me, this was this is probably, I don't know, a couple hundred study. I think somewhere on the order of 5 to 10 people. But if you're, and you're not going to get probably that many more people who are going to be that engaged in what you're doing. There's different scales of how you do this. So like you could actually pay people to do that, in which case you could get a lot more people, and you could really get into the, you could really get a much better cognitive test. They might be people who don't necessarily know you or like you or want to spend time with you, which is actually the best people to get in some ways, because they're willing to say things and give you a perspective that you might not have if you just ask your friends. So, I mean, as many as possible, but really I think that there's diminishing returns after about, probably even in a big survey, after about 10 or 15 people, because what you really want is you want to really ask them a lot about the stuff. It's not that you need a ton of people. And more often than not, the big problems, like all of them will identify, if 50% of the 5 to 10 people identify a problem, then you have to pay attention to it. Anything else? All right, terrific. Thanks so much.
Thanks, Pari. Very concise and thorough at the same time. Very well done. It's with great pleasure that I announce our final speaker. Catherine Maturin is a abdominal radiologist, member of the faculty at the University of Michigan, and is also an author of over 30 articles in peer-reviewed publications, is a senior giraffe fellow through the AUR, and is quite an expert in survey methodology as well. She's going to be presenting, collecting, and interpreting survey data.
Hi, thanks for being here. I'm Kate Maturin, and it's kind of a long day for you guys, so I appreciate that you're still hanging in there. Okay, so I'm going to talk about collecting and interpreting survey data, which is a topic that overlaps quite a bit with what Pari was talking about. So there's going to be some overlap, but like my high school debate coach used to say, repetition is very persuasive. So that may help to emphasize some of these ideas. None of this pertains to this content. My goal after doing this talk is to convince you that survey research is both more interesting and harder than it looks. And so that is something that I've learned by doing it. But more specifically, we're going to look at a couple of threats to validity in your survey design and describe the impact of sampling and your approach to sampling on the interpretation and solidity of your conclusions. And then basically just to look at the potential complexity of doing this kind of work and to seek expert input when it's appropriate. So I just want to use a couple of moments to look at some of the terminology here. So a survey, generally speaking, is a standardized procedure for gathering information about a population. So it might be a questionnaire, or it might be something else, and some kind of a measurement, some other kind of device that gives you information about a population. It's usually impractical to collect an entire population. So a sample of that population is taken. A sampling method is how we get from the big population of interest to the sample that we're using to make inference about that larger population. And the sampling method really should be carefully designed. And that's something that I've really not seen very much attention to at all among the kinds of surveys that we generally do in radiology. And it's something that survey methodologists talk about a lot. A questionnaire is the specific tool that was used here for the resident survey and is usually the most common tool that we're talking about. But that's something a little bit different than a survey. So our language could be slightly more precise if we differentiate those two. So we can look at this survey process from two different directions. And the first direction is known as the measurement perspective. So what are we trying to measure? Or, if in the case of a questionnaire, what are we asking? So we're going to look at what we're asking and who we're asking it of. If we're looking at what we're asking, we start by describing a construct. So this is that conceptual domain or that whole, just the cognitive space that we're trying to work in. And this is the unit of information that the researcher is trying to glean about the population, no matter what that is. It's the element of information that you're looking for. And if you can develop and refine this construct, you're going to get a better result. And that's similar to somebody ordering an abdomen CT, right? If they give you a better question that's more refined and more specific, you're more likely to give them a better answer. And surveys work the same way. So measurement is what we're going to do to get that information out of the population. So the measurement can be a questionnaire, or it can be something different. If I wanted to know whether a person is anxious, I could ask them, do you feel anxious? Or I could use some kind of a standardized method of looking at subjective parameters of anxiety, like are your palms sweaty, do you feel jittery? Or I could actually use biophysical parameters that are known to evaluate anxiety. So those are all different ways to measure what I'm looking for from my construct. When I've developed my measurement tool, I'll get a response. And that response is only as good as the measurement tool. And it's also only as good as the attention that the person who is your participant is able to give to the process. So if you have a really, really long survey, you may actually degrade the quality of your responses. I'm not talking about response rate here, but the integrity of that data, because the person is just going to get bored and they're just like, fine, fine, click, click, enough already. And we've all had that experience, right? Taking all these online surveys. And so you need to keep the process within the constraints of the party who's filling out the survey or who's doing the procedure. Or if I was doing a blood pressure measurement survey, it would only be as good as my blood pressure cuff, right? So there's a lot of different ways that error could be introduced at this stage. When I have these responses, I'm going to collate them into some kind of a spreadsheet or another place where I can work from to do my statistical analysis. But there's an editing process here, and this is a place where errors can also be introduced. And we've all heard of coding data. So there can be coding errors, or errors could be caught. We can realize that the respondent in the old days of paper was somehow missing a question and skipped and got the wrong answer. You can figure out things that went wrong in your survey if you failed to realize those in the pilot phase, or you can introduce new errors. So this can go either way, but it's a place where your data is being transformed from that response domain into something that's a pile of numbers that you can do statistical analysis on. So then you do your analysis and you wind up with a survey statistic. And that's usually a mean or a proportion or a frequency. So some kind of a value that we're trying to learn about our core population. So that's what we're asking and why we're asking it. Then the question is, who are we asking? So this is an example of a whole population. And it turns out these are the population of people with colorful ponchos. I don't know why they're wearing them, but we wanted to survey that whole population. If we wanted every single one of them, that would be a census, right? And so the most common census is the US Census, or the one that we talk about. And that's an example of a survey where you're really trying to catch every single person in the population. The US government thinks that they're asking every single person, more or less, that same series of questions. Usually that's not practical for researchers. It's marginally practical for the chief residents, and they might be able to get actually every single chief resident because we know their names and we know where they work, and we could track them down, and that's what the census does, right? So you could do a survey without using any method of sampling if you have a defined population that you have some control over. Much more common, though, is that you'll take a subset of that group. You'll take a sample. Now, this is a sample that only has a few kids in it, but even in that sample, there's some kids that are raising their hand and there's some kids that aren't, right? And here's where the response rate comes in. What if I really want to know what these kids are saying? I'm not sure whose arm that is, so I'm going to pretend like this girl is underrepresented because that seems more PC. Maybe this boy is underrepresented. Somebody's not answering here, and that's the non-response component. So this is the who are we asking it of part of the issue. This is the representation perspective. Is the population represented in the group of people to whom you're administering a questionnaire or another survey? And that's your target population. So if you wanted to know about everybody who uses the internet, that's a pretty huge population, and you really can't do a census of that, so you're going to find a way to sample it. And the way that you define that sampling procedure is known as the sampling frame. So imagine like a rectangle that just encloses the group of people that you're going to survey. That rectangle is defined by your means of finding them. So if I wanted to survey all of the internet users, but I'm going to use a sampling frame of the Gmail users, now I've established a subset of people that I'm going to survey. But you can all imagine that I'm creating a bias already in my response there, right? Because that's probably going to skew a little younger. All these Hotmail and AOL users are going to be totally underrepresented. So your sampling frame and your choice of that frame makes a difference. But even that frame might be too large to realistically achieve. So within that, you're going to get a sample. And a sample is an even smaller group, and that's that little set of kids. So that's one elementary school, or that's 5 programs, or that's 3 institutions. And so that's the actual sample that you're getting. And you need to think carefully about the relationship of that sample, both to the frame and then to the larger target population about whom you really want to be able to make inference. Among that sample, we have the respondents. And those are the kids who are all raising their hands. Those are the respondents. And I know basically chief residents are like that. I'm basically like that. So we're all going to be raising our hand, and somebody else is not going to be raising their hand, and their answer is not going to be recorded. And that's the issue that Pari was referring to of the response rate. I just want to put a slight wrinkle on that and say that it's not always the case that a response rate equals the response bias. And I'm sure that is also something that Pari would acknowledge. It depends on the nature of the non-response. But the problem is that that's very hard to characterize. So in this era of ubiquitous surveys everywhere, internet surveys every day, somebody asks you to survey something, right? Non-response rates are sky high, but that doesn't always mean that a non-response bias is present. It's only if that non-responding group is different qualitatively or quantitatively from the people who did respond that a bias is necessarily present. The problem is that it's incredibly hard to capture what those criteria are in that non-responding group if they won't answer any of your questions. And so this is something you can think about and you can try to account for. In the absence of being able to account for it, it's absolutely the case that having a higher rate is more likely to protect you from a non-response bias. But non-response bias and non-response rate do not always have to be in lockstep. So now we've got our data from all of our respondents, and we're going to do some post-survey adjustments. And this is the kind of thing that radiologists do not know how to do. We are not powered for this. And this is stuff like imputation for missing data. This is stuff like weighting of different strata if you do a stratified sampling method, and this is what Pari was referring to, that I'd like to, you could either oversample those people intentionally, or you could artifactually or mathematically weight their responses when you're calculating your population mean so that it reflects more accurately what you think that umbrella population looks like. So this is a lot of math, actually. Eventually you get there and you've got your survey statistic. And again, that's your mean or your proportion or your frequency that you were looking for. So the thing to remember, though, is that your result is just that. It's a result that derives from your sample. It's an estimate that's specific to the group of people that you asked. From that, you want to be able to go backwards and infer about the whole population, but you need to be conscious about that process. So in this whole population is where the true value that you're looking for, that true number, lies. And if I sent out 3 different researchers, or if I myself did the same procedure on 3 different days, I'd get 3 different, what they call simple random samples. I might get 3 different samples. I did the same procedure for each of them, the same questionnaire, or whatever the method is, and I get 3 different estimates of that mean value. So these are the distributions for each of these samples, and they look pretty different, and each of them has a pretty different mean value, and they also have a different standard deviation. So there's a different spread in each of those pieces of data. If we can imagine that the true population mean looks something like this graph here, so the likelihood that on any given day I was to take a sample and I got this result, or this result, or this result, is actually equal. All of these things are possible results that could happen when you take a small sample that reflects the larger population. If you have a good sampling method, this range is going to change. And I'm going to show you another graph that I think shows that more clearly. But just imagine right now that my 3 different populations all could legitimately be somewhere on this bell curve. And it's the shape of that bell curve that's going to determine how accurately you can make inference from your own results from a single sample. So every sample has an intrinsic error, right? If we imagine that the true number that we're trying to get to is 50%, and we're going to look at this blue line here, where we have a relatively small sample size of 96 respondents or participants. Any day that I take a simple random sample, or a so-called draw from that population, I could get a value that lies anywhere on this blue line. The height of this curve reflects the likelihood of that event. So I'm just as likely, pretty much, to get an answer that's about 47 as I am to get an answer that's about 50. And I'm still fairly likely to get an answer that's 42, or an answer that's 58. So the range of my estimate, or the confidence interval of my estimate, the standard deviation of my estimate, those are all basically expressions of the same thing. It's really wide, right? And so I have a very smudgy answer here. It's a big charcoal pencil, and it's just kind of blurred all over the place. If I take a larger sample size, those shoulders or the spread or the range of that data shrink in. And so I have much more confidence that my estimate reflects the true population mean, because it's much more probable that if I take draws anywhere along here, I'm going to be somewhere close to this middle line, which is the 50% value. So just to say it a slightly different way, the spread of the data is a function of the sample size. And the standard deviation, or the spread of the data, decreases at a rate that's proportional to the square root of the sample size, or the n. So an infinitely large sample would give you the right number. We can't usually get there, though, right? Luckily, there's this concept of the law of large numbers, or the central limit theorem, which says that essentially if you take in a sufficiently large number of iterations, that any number of distributions will converge on the mean, or will converge on the true value, and they will take an approximately normal distribution. And it's because of this that we can make a lot of the inference that we do, and that we can use a lot of the techniques that we do. For example, we can use parametric statistics, which are really for normal distributions, even when we have a little bit of an off-normal distribution, because we think, boy, if I had more numbers, most likely this would get to the point where it's actually a normal distribution. For the same reason, when you have a sufficiently large number of iterations, you're going to get a proportion or an estimate of that proportion that's pretty close to the true mean. So this is a pretty important concept in statistics, and a lot of people, they really take it to heart. He wonders what life would be like without the central limit theorem. This is another graphical illustration of the same concept. And again, this is the same idea that if you have a small standard deviation, you have a probabilistic likelihood of your estimate falling somewhere on the curve that's somewhere close to the true value. In this case, we're looking at a treatment effect. And the real value is 0 in this case. There's no treatment effect. And if you did a procedure that gave you the wrong inference, you'd say there was either a big treatment effect that was positive or a big negative treatment effect. And you publish a paper where you were saying something that was wrong and it would make you look really stupid. So the important part here is that you want to have appropriate confidence in the validity of your inference based on those sampling distributions and on those standard errors. So if I take a sampling distribution that has a large standard deviation, either because it's small or because in some other way it's messy, there's all this probability out here in the tails, right? This is, again, the same concept that on any given day, if I took a draw from this population, I could get this number or this number with equal likelihood. And that's only about half as likely as getting the true value. So I might conclude that there was a +5 treatment effect and publish that. So that's the importance of sample size and of standard deviation in the validity of your conclusions. To just say it again, the impact of that increasing sample size is to increase the likelihood that your estimate from a single sample approximates the true mean in the population so that you can make the correct inference with a relatively narrow confidence interval. Okay, so if we look at overall sources of error in survey research, you can think of it in 3 domains. One of them is non-observation, and that's what I've been focusing on so far, which is these coverage and sampling issues, and also non-response. So if we fail to observe something, we just don't know what it was, and we might make the wrong inference as a result of that. Or we could observe the wrong thing because we ask our question in a dumb way and the person can't understand it. Or we're using a telephone interviewer who makes an assumption about the way that a person answered the question, or just simply makes an error in writing it down. Or the respondent makes an error when we have an unclear method of administration with too many radio buttons. These are all ways that you can get the wrong information. Then we can screw it up ourselves when we get the data, right? We can process it in such a way that it becomes degraded in some way. We can make coding errors, and our post-survey adjustments like weighting and imputation could actually make things worse. We could introduce new errors by doing that. So this seems hard, right? This seems really complicated, and that's why I'm kind of defaulting to the Ask a Professional, which is the same thing that Pari said, but this is an example of some actors impersonating doctors, right? And here's one person who's mask ventilating the patient, somebody else is doing an abdominal exam, somebody else is reading an x-ray in the air. I mean, they do not look like they know what they're doing. And honestly, I'm not sure that we really do either when we do survey research. So social scientists do certain things that we should also be doing when we do these procedures. And one of them is to examine your goals. So this is that first concept of identifying and defining your construct. What am I really trying to ask? What is the unit of information that I want? Take your time. So this is kind of, ironic information for me to be putting out there because I'm a person who's always in a rush. I want to get that survey put together so I can submit the IRB and get this process moving. It's not going to work as well if you do that. So you do need to take your time to pilot test and to do all these evaluative procedures that will get you to a more valid instrument. Any social scientist would tell you you need to build cross-checks into your questionnaire. So if this is the important question that you really want to know the answer to, you should ask it twice. You can ask it 2 different ways, or you can ask it backwards one time and then reverse code it so that it gives you the same result. You should confirm if there's something that's really important to you, that that's the answer that you're getting and the answer that you want. Now, if you're testing a hypothesis, which is a little bit of a thing we haven't quite made explicit here, there's surveys where people are just trying to get the lay of the land. And I would say that the resident survey is a little bit like that. It's like we just want to know what's out there, and it's mostly descriptive. There are other kinds of surveys where you're really doing a hypothesis testing exercise. You might know at the beginning what the conclusion is that you'd like to be able to draw. So if you know what the conclusion is that you want to be able to draw, then you should make your setup such that you will actually be able to draw it. So that's where this issue of power calculations and sort of thinking backwards from the end comes in. And this is, again, something that a person who is an expert in survey methods will be much more equipped to do. Because this is what they do, okay? This is estimating the variance. They are obsessed with the variance, as I've just expressed by showing you all these bell curves with these shoulders on them. This issue of variance, of how big is the spread of your data, is like, bread and butter to them. So I don't want to do this, and this is not something that I'm qualified to do. So what should I do? What can we do? And I'm just going to go through a few examples of questions that could be refined, because I think this is the main place that we're going to be involved, is writing questions. So once we've thought about what our construct is, we're going to write a bunch of questions. And those questions usually need more work than we give them. This is my own survey, so I'm just going to come right up here first and expose my own, I think, haste in the way that I put this together. This is something that a telephone interviewer is giving. So the respondent isn't actually looking at this, but the telephone interviewer is asking these questions and then writing things down here. So first of all, age. Okay, that seems like fairly innocuous, right? How old are you? Well, what if they're lying? What if they're not going to tell you the right answer because they're senile? It may not matter. But if it does matter to you, then you need to have their birth date also somewhere on the survey, or you need to have an ability to check it with their medical record. If that is an important unit of information to you, you should check it. What about this? Race. Okay, white, black, Hispanic, and other. What is other? I think I saw this someplace, but other is a wastebasket category where people could put anything. They might be saying to me, I hate your question, or I hate your survey, or I'm mixed, or I'm Chinese, or I don't think these are races, I think race is an artificial construct of our society. Who knows what they're saying? But it doesn't give me any information as the researcher. So other is probably a category to be avoided. And I did the same thing here, and I did the same thing here. So if you want to know more, you can't be putting a bunch of others, because you're going to wind up getting a lot of others, and they're not informative. Okay, what about ever pregnant? So in this case, it worked out, because that's all I really wanted to know, is literally, have you ever been pregnant? I didn't want to know if they had living children, if they had tried to get pregnant and couldn't, if they'd had elective abortions or miscarriages. I didn't want to know any of that. But if you did, you can't just ask ever pregnant, because that is not going to deliver as a question. So you just really need to ask, what do you want to know? Okay, so that's my survey, which was a little disappointing in retrospect after I learned more about survey research. Here's something I just got in my email in the last couple of months. Does anybody know what's wrong with this one? Yeah, so, I had a birthday this year. I'm going to go ahead and throw that out there. And I, as such, cannot answer this question because there are 2 possibilities for me. And I might go with the age range that I would prefer, or I might go with the age range that I would legitimately be entering into. But either way, the researchers aren't going to know exactly how old I am, right? Don't make those answer options overlap. Here's another one. And this is a little bit wordy. It's a little bit hard to read, but please rank the following studies in terms of priority to be read overnight versus the following morning. Now, to me, when I hear about ranking, I think about putting things in an order. So I might want to see like either numbers or an ability to move those items around. That would be pretty cool coding-wise, but put things in an order. But instead, we're going to rank these things on a scale of strongly agree to strongly disagree. I don't really know what this means, to disagree with an inpatient study non-urgent indication. Like, that just doesn't make sense to me. And I think if you actually sit down and thought about what does this question and this answer set mean on its own, I can't agree or disagree with that. That's a thing, and it's not informative the way that it's written, and it's probably not going to deliver as a questionnaire, unfortunately, for the researchers. Here's another one, and I think this might have come from somewhere in the AUR. So You may have also seen this one, and again, I have made these exact same mistakes and worse ones, and so please don't anyone take offense if this is your survey. But I think this one's a little bit wordy. So I think they're trying to say, is it hard to use your monitors? So let's just ask that. And let's be as specific and concise and precise as we can, because in general, when you write surveys, they're supposed to be written at an 8th grade reading level. Now, when you're going to survey a bunch of doctors, you could probably make it higher, but remember that a lot of doctors have the attention span of a baby gnat, so you can't make it so convoluted that they won't be able to follow the whole question. And then we're going to go with our answer choices, which range from not difficult or easy. So let's just pick one of those. How about either easy or difficult? You know, when you put all these different qualifiers in here, it makes it hard to see the point of it. So that's okay, no problem. I'm going to answer that. It's either hard or it's not hard. But on the next question, the direction reverses. And all of a sudden, good or easy is on this end, and it was on this end here. And this is a great way to get responses that are completely wrong. And you'll never know it, because there's no way to detect this unless you happen to answer the same question somewhere else in your survey. So keep the answer choices consistent if you have a panel of questions that have analogous responses, because if you switch it, just out of sheer inattention and hurry, people will be likely to give you bad data. Okay, then here's the last one, and this is another ranking task from the same survey. So I try to give feedback to residents most times. Yeah, since I believe that my efforts make an impact. Okay, yeah, but are those the same thing? Can that be all one question? Remember when we were learning medical interviewing, you're not supposed to stack questions, right? You're not supposed to say, so have you had fever, chills, immune deficiency, flatulence, or erectile dysfunction? The person has no idea how to answer that. So you can't stack up these different constructs in one question. And I would say the same thing happens here. So I do try to give feedback to residents most times, but I have no idea whether my efforts make an impact. I'm going to go ahead and say that, but I said strongly agree anyway. And then this one. Most times I find the feedback I give residents does not result in fewer errors. So I think I have at least 2 negatives here, so I'm kind of into double negative territory. And then I just wound up going with the garbage category because I couldn't figure out really how to answer that. So I said neither agree or to disagree. And unfortunately, that's not going to help the researchers, right? That's that middle category, and that is the analogous thing to other. It is just a dumping ground for uncertainty and all kinds of responses to this question, which may include, I don't understand your question, and I'm going on to the next one. So I'm going to just say neutral. So if you can try to write your question in such a way that the answers are easy to understand and sort of schematized, you're more likely to get data that you can use. And that's, I think, what we can mostly do. We can consult an expert, we can write our questions better, and we can know what we're trying to ask about and where we're trying to get to with this process. So to conclude, again, refine that construct, really define what you're trying to identify, what's your unit of information, write those options carefully, and pilot test the questionnaire to see if it works and to see how it performs. That's the what are we asking. And then the who are we asking. Again, think about your population of interest very broadly. Decide how you're going to sample it and the pros and cons. No sampling frame is perfect, but the way that you capture that population is something you can only think about at the beginning of your study and change it. You can't think about that at the end and then go, oh God, I wish we would have done this and that. If you think about it at the beginning, you're going to have a better basis for inference at the end. What are the issues with non-response in your specific context? Is there relative homogeneity in the population in these parameters that you think might introduce bias? If there is, then you're lucky. If your response rate may not mean a response bias, but in other cases it would, as the example of people who are too busy to fill out a survey about how busy they are. And finally, ask a survey methodologist. And this is a book that I used for a recent course that I took, which is really technical, but it has a lot of interesting concepts in it, and I referenced it several times, so I just thought I'd show you the picture. So thank you very much for your attention, and I'll be happy to take any questions.
Thanks, Kate. I had a quick question about if you are doing a pre-survey, an intervention, and a post-survey. If you, it's kind of a two-part question. If you sample low-tech and do a paper survey, the initial time, how important is it to kind of do the post-survey in the same way? Do you think it has any factors?
I think you could get away with doing it 2 different ways if it became necessary. I think it'd be preferable to do it the same way. It's kind of one of those things like the red face test. If you could imagine getting up and saying, justifying your research choice, and you have a good reason for it, you could do it either way.
I see.
But I don't think it would be a deal breaker, but there's no reason to switch it if you didn't have to. You always want to have as much homogeneity as you can so that there's no introduction of bias.
And my follow-up question to that is, if you, in fact, do an intervention and want to measure the outcome, would you think that it's important to include your pre-questions in the post-survey if in the pre-questions you were just sort of trying to get a lay of the land?
I guess it depends if it was like knowledge content or was it attitudes or both?
Attitudes.
And then it depends whether you want to analyze it on an individual level or on an aggregate level, because you could do a paired comparison where you're looking at one person pre and post, but that requires usually, like you need to specify that in your IRB, for example, if you're going to hold on to somebody's data and then link it with their data afterwards. In some ways that could be more powerful if you're going to do a pairwise comparison, but you could just talk about the whole group and talk about the group means, and you wouldn't necessarily have to be comparing them person to person. As to having the same questions, I think you probably would want to have the same questions, unless somehow it became no longer relevant. It's hard to know exactly.
Okay, thank you.
Thanks, Kelsey. Thanks, everybody. All right, go have happy hour.